What is the impact of lives now on patients who, if they discontinue ARNI therapy? We have now a lot of evidence, and what it shows is that once we withdraw ARNI, this is very important. It itself is a cause for increase in mortality. We often see people who have reduced the dose of ARNI on their own because of various factors like economic causes, and they often come back with worsening of ejection fraction, worsening of heart failure, and in any study, registry data, they have demonstrated increased all-cause mortality when there is non-compliance or ARNI withdrawal. This is also an important call. We put a patient on ARNI. The LV ejection fraction improves and the patient has complete resolution of all signs of heart failure. Initially it's clinical, then his biomarkers become normal, his echo becomes normal. What do we do? Should we stop the drug? One must remember, whenever one stops this drug, there is a lot of evidence to show that his condition may worsen. So, if it's a very young patient and it's a myocarditis, which one feels is reversible, or if one thinks it's a reversible cause, well, I think one can consider that we can reduce the dose of ARNI. But in general, it is safer to continue with ARNI because as this chart shows us that when we follow up the individuals who are having a low ejection fraction, there is an improvement. You know, people who have severe LV dysfunction, many of them will have improvement. But the problem is when we discontinue, a significant number of them will show worsening in their ejection fraction, worsening in their heart failure, and even mortality. So improved LVEF, one should continue with guideline-based medical therapy to prevent relapse of heart failure and LV dysfunction. So this is a class 1 recommendation. It has provided new hope to people who have heart failure with low ejection fraction. It can reverse the adverse LV remodeling. It can improve quality of life. These benefits are not restricted to those with very low ejection fraction. It is also seen in people with heart failure with mildly reduced ejection fraction. And there's some benefit certainly in people with heart failure with preserved ejection fraction. It should be initiated as early as possible in both acute decompensated heart failure and de novo heart failure. One must remember to continue and encourage the patient to persist with full guideline-based medical therapy. This is independent of the fact whether that person is undergoing device therapy, ICD or CRTD. With these points in mind, we must also tell the patient to remain on a follow-up. And with any worsening symptom, that person should not wait for his next follow-up, but should come in case he's having giddiness, he's having weakness, he's having breathlessness, and so he should not neglect these symptoms. He should come in for a clinical examination along with blood tests which will show us whether his heart failure markers are all right, whether his electrolytes are all right, his tissue perfusion is all right. So we must expand the use of guideline-based medical therapy of ARNI in our heart failure population. Thank you.